Our program will now begin.
I'd like to welcome our audience today to the 20th annual John Collins Harvey Lecture, sponsored by the Pellegrino Center for Clinical Bioethics at Georgetown University. My name is Miles Sheehan. I'm director of the Pellegrino Center for Clinical Bioethics, a professor of medicine, and David Lawler Chair for Catholic Healthcare Ethics at Georgetown University Medical Center. And I look forward today to our conversation on covert consciousness, neuroscience, and normative obligations. Before I introduce our distinguished guests for this Harvey Lecture, please allow me to share with you just a little bit about Dr. John Harvey. Dr. Harvey was a distinguished clinician, researcher, and medical educator. A graduate of Yale and then the Johns Hopkins Medical School, Dr. Harvey was a faculty member at Hopkins before moving to Georgetown University in 1973. Dr. Harvey was a leader in establishing the specialty of geriatric medicine. He was also a man of deep Catholic faith, and in 1989 acquired a PhD in moral theology from St. Mary's Seminary and University in Baltimore. Dr. Harvey was a close friend of Dr. Edmund Pellegrino, and he worked as faculty with Georgetown Center for Clinical.Bioethics until his death in 2017. Having had the privilege of meeting Dr. Harvey, I can testify to his warmth, his humor, his erudition. He's really a great guy. Dr. Finns today is also a great guy, and he is the E. William Davis Jr., MD, Professor of Medical Ethics and Chief of the Division of Medical Ethics at Weill Cornell Medical College, where he is a tenured professor of medicine and chair of the Ethics Committee of New York Presbyterian Weill Cornell Medical Center. Some 2 decades ago, I had the joy of meeting Dr. Finns as we were both faculty scholars on the Project on Death in America, sponsored by the Open Society Institute. At Yale Law School, Dr. Finns is the Solomon Center Distinguished Scholar in Medicine, Bioethics, and the Law, and a visiting professor of law. The author of over 500 papers, chapters, essays, and books. His most recent book is from Cambridge University Press, Rights Come to Mind, Brain Injury, Ethics, and the Struggle for Consciousness. Dr. Finns is an elected member of the National Academy of Medicine, of the National Academies of Sciences, Engineering, and Medicine, a fellow of the American Academy of Arts and Sciences, and by royal appointment an honored academic of the Royal National Academy of Medicine of Spain. Dr. Finns is president of the International Neuroethics Society, a past president of the American Society for Bioethics and Humanities, and is chair-elect of the Hastings Center's Board of Trustees. Dr. Finns is also a trustee emeritus of Wesleyan University, which has recognized him with an honorary Doctor of Humane Letters. I'm also delighted to introduce Dr. Jim Giordano, PhD, MPhil, who will moderate our conversation today with Dr. Finns. Jim at the Pellegrino Center is chief of our Neuroethics Studies program, scholar in residence, leads the sub-program in military medical ethics, is co-director of the O'Neill Pellegrino program in brain science, as well as the global health law and policy. Dr. Giordano is professor in the departments of neurology and biochemistry at Georgetown University Medical Center, the author of over 250 publications in neuroscience and neuroethics, 7 books, 15 government white papers on neurotechnology, ethics, and biosecurity. Jim is an editor-in-chief of the international journal Philosophy, Ethics, and Humanities in Medicine, associate editor of the Cambridge Quarterly of Healthcare Ethics, and contributing editor of Frontiers in Neuroscience. His ongoing research addresses the neurobiological bases of neuropsychiatric spectrum disorders and neuroethical issues arising in and from the development, use, and misuse of neuroscience techniques and neurotechnologies in medicine, public life, global health, and military applications. In recognition of his work, Dr. Giordano was elected to membership in the European Academy of Science and Arts, named an Overseas Fellow of the Royal Society of Medicine of the United Kingdom, received City University of New York's Outstanding Alumnus Award, as well as Coburg University's Gold Medal for Distinguished Achievement, and he is awarded Germany's Klaus Reichert Prize in Medicine and Philosophy. I'm delighted that Dr. Finns is with us, and I really look forward to Dr. Finns and Dr. Giordano having a great conversation. Thank you so much.
Thanks so much, Miles, and thanks to each and all of you for being here with us today on this 20th annual John Collins Harvey Lecture. Having known Dr. Harvey myself and actually occupying his office after he left Georgetown, I had the rich experience of not only interacting with him professionally, but getting to know him personally. And truly, he was a great guy and very much dedicated to the idea of bringing forth these types of discourses to be conversational, not necessarily to be something formal and stuffy, but really to be something more of a journey rather than a destination. And of course, I've known Dr. Joe Finns for going on 21 years now. We first met in about 2020, I guess it was almost about 2022, or 2002. So it's been about 20 some odd years since we've known each other. And of course, I've known him not only for his direct work in bioethics as it interfaces with so much of neurology, but he's been a leading figure in the international neuroethics community. And this field, neuroethics, a somewhat new field that really came into full being in the early 2000s, I think has been a major part of focusing much of his clinical work and work in bioethics and humanities and key questions that speak to the essence of what makes us, us. The nature of being, the nature of consciousness. And of course, this is certainly tantamount and brought to stark relief into his most recent book, which is Rights Come to Mind, Brain Injury, Ethics and the Struggle for Consciousness, published in 2015 by Cambridge University Press. It's a real pleasure to have you here, Joe. So what I'd like to do for our folks here today is, as I mentioned, this is sort of a destination in one part. Our destination is to talk about covert consciousness. But I think would be very interesting for those in our audience who may not know you is that your journey to this point has been rather interesting. Has been a bit of Brownian motion, but also a bit of intent. And you went into palliative care first, and that brought you to where you are today. Tell us about that.
Right. Well, thank you, Jim, and Miles, thank you, and to the Pellegrino Center and to the memory of Dr. Harvey. I'm really honored to be here for the 20th conversation. Yeah, so it wasn't where I intended to end up, but I think that's a good lesson for young people watching this. You don't always know where you're ending up at the beginning of the journey. And Kierkegaard said life is, live forward, but it's understood backwards. So in retrospect, it all makes sense, but in the moment it didn't. And in the 90s and the early noughts, I was trying to help improve the quality of care of people at the end of life. And that's where I met Miles with the Project on Death in America. And as I was writing about death and dying, and I wrote a book called The Palliative Ethic of Care, Clinical Wisdom at Life's End, bringing up notions of phronesis and how do you integrate theory and practice together and improve how people die. I got interested in the Quinlan case and the right to die. And around the same time in the late 90s, I ran into a colleague of mine here at Cornell, Nico Schiff, who's a neurologist, who was getting it and who was a protege of Fred Plum, who was the originator of the vegetative state with Brian Jeanette back in 1972. Fred was both of our teachers here at Cornell. And Nico was interested in patients with disorders of consciousness and was beginning to envision doing work that ultimately we did using deep brain stimulation in the minimally conscious state, a category that was only discovered and codified in 2002. So we're winding up into this thing, and I realized that this whole population of people with these disorders of consciousness had sort of been marginalized, and the neglect really devolves back to the establishment of the right to die. The right to die was established in Quinlan because, as Judge Hughes, who by the way was a very strict Catholic and was the chief judge of the New Jersey Supreme Court, talked about her loss of a cognitive sapient state as being the moral warrant for her right to die, given her the fact that it was essentially a feudal situation. And what I realized over the ensuing years is from my basis in palliative care and end-of-life care, was that we had overgeneralized these notions of futility to a population that might have not been as futile as we thought. And that nested within the vegetative state, because we only had a name for the vegetative state, was another population of people called the minimally conscious state, who actually had a liminal state of consciousness and whose prognosis was vastly different than people in the vegetative state. And that became my focus and my concern, that these people who were conscious and unrecognized were living in nursing homes and being undiagnosed and not properly treated. So the notion of covert consciousness has two kinds of meanings. One is a sociologic meaning of covert conscious. Somebody is conscious and we don't care to recognize that because people are in nursing homes, they're not getting good medical surveillance, and they might be evidencing evidence of understanding and awareness and interaction with their environment, but nobody believes it. So for my book, Rights Come to Mind, I had interviewed like 50 families about their experiences. And some of the families said, I thought my loved one looked up when I came into the room, or I thought they responded to their name. And then they tell the doctor, often a geriatrician who comes in once a week, because these people end up in nursing homes as if they had end-stage dementia, not young people with brain injury. And they say to the doctor, I think, Johnny was responding to his name. And of course, the doctor says, Johnny, you there? Can you look up, Johnny? And the problem with the minimally conscious state is that they have episodic and intermittent awareness of self, others, and the environment, but they don't do it reliably. So they don't do it on cue. So the doctor who walks in once a week and doesn't know anything much about neurology assumes that it's wishful thinking, that the family is sort of dreaming that they saw this inference of responsiveness, when in fact, that's the biology of the circumstance. So that's one kind of covert consciousness, that it's there, but we don't see it. It's hidden, but it's there. The other kind of covert consciousness, which I just want to put on the table, is a kind of a biological framing of it. And these are patients who they in fact are behaviorally vegetative. And by vegetative state, they're people who have a state of wakeful unresponsiveness. They're not responding to their environment, and they look like they're totally unresponsive. But Jim, if you put them in the scanner and you say, imagine walking through your house, imagine playing tennis, imagine disaggregating words like a riverbed creek or a creek in your neck, they light up the motor, spatial, or language areas of their brain that suggest, hey, there's a disconnect, a discordance between the behaviors they manifest with her, and what's going on inside their brain. And that's also a covert kind of consciousness, which has been described as cognitive motor dissociation. So there's a dissociation between the behaviors, the motor activities, I'm waving my hands, or I could also be imagining waving my hands right now. And my brain, if you did an fMRI, would be doing the same thing. And what's interesting, it's not a passive response, it's volitional, because you would ask me, Joe, imagine playing tennis. So I'm thinking, okay, I hear imagine playing tennis, and I say, okay, I'm going to play forehand, backhand, right? But I've got to think about that. And those motor activities can light up specific areas in the brain. So the technology has enabled us to see that there is an entity such as covert consciousness or cognitive motor behavior, motor dissociation, which was unavailable to us before we had the technology.
Well, let's use that as a pivot point, if we will, because so much of what you're saying that's critical to the way we regard and treat these persons who've been rendered into patienthood by their predicament of brain injury or some other form of neurotrauma really speaks to the ethics of the way we use the existing science and technology. You and I have been involved in the field of neuroethics for the past 2 decades and change. And you've referred to neuroethics as an ethics of science and technology.
Right.
You can sort of expand on that, because I think that's important for our audience here today.
Right. So it is an ethics. I think it is an ethics of technology, because without the technology, we wouldn't be able to know that there was a discordance between the behaviors and what's going on inside the brain. In fact, if you go back to the original paper that Fred Plum wrote with Brian Jeanette, and his co-author, Brian Jeanette, is also known for all the Glasgow, as you know, all the Glasgow coma scales and Glasgow outcome scales. And Fred was also known for the locked-in state, which he described in 1966. You have these two giants in neurology and neurosurgery coming together to write the vegetative state patient in the Lancet, and they called it a syndrome without a name. And I think it's a great paper to read if you're interested in just good, crisp scientific writing and logic. So Fred writes, and he was a great wordsmith and editor, he writes that they seem to be wakeful without responsiveness. And by that, he said, we really can't know. they seem wakeful without responsive because absent the ability to peer inside the injured brain because of the technology of functional neuroimaging, which requires informatics and computer science and advanced radiology and isotopes, all that technology allows us to peer inside the injured brain. So you don't know you have an ethical problem, right? Because before all we had was the behavioral manifestations. It's like Mendel's garden, right? In genetics, it's having phenotype without an awareness that there may be an underlying genotype, and that third generation of P may be a heterozygote, and what looks white is going to be pink in the next generation, or what's pink is going to be white in the next generation, because they're not really the same at a genetic level. So these patients who may all appear to be vegetative may be very different on the inside. And that's what the technology has allowed us to understand. And it's kind of like in the old days, perhaps before there was the advent of the microscope, people have lumps in their neck, and the physician before the microscope, before histology, before pathology, would say it's interesting. Some of the people who have lumps in their neck die quickly, and some of the people die sort of quickly, and some of them don't die at all. One had an infection, it was a big lymph node. One had a lymphoma, and the other one had a goiter. But until you were able to look at the differences under a microscope, they might all look the same. And so we're beginning to understand that there's a difference between how you manifest in the world and the underlying circuitry and the biology. So on a diagnostic side, neuroethics is an ethics of technology. On the therapeutic side, it's also an ethics of technology because, and we can talk more about this, we can use that same functional magnetic resonance imaging as a way of establishing a communication channel with that person who's locked inside their head. So, and this has been done. Martin Monti did this study in the New England Journal of Medicine, building on earlier work. They said, okay, imagine walking through your house for yes, and imagine playing tennis for no, or the other way around. I don't remember. So somebody who now can volitionally think about those things, who was unable to manifest a behavior, is now able to manifestly communicate. And the work that we did, and we published in Nature in 2007, was to put a deep brain stimulator or electrodes into the thalamus of the brain of a person who was in the minimally conscious state, who couldn't talk, could only move an eye sometimes in response to his environment, was able to say 6 or 7 word sentences, tell his mother he loved her, go to Old Navy and choose clothing for his mother to buy, and tell her that he loved her. So here the technology responds to the problem. Now, of course, we have to add values to the technology. Doesn't solve all. It just illustrates and perhaps guides a way, but it doesn't tell us what the right thing to do. And there are questions of suffering and burden, all those other things.
But let's back up just a moment, because one of the criticisms, as you know, against both the overt, if not overuse, of various forms of neuroimaging, together with interventional neurotechnologies, not only being able to access the living brain, which in this case is important for defining and assessing whether consciousness is there or not, but affecting the living brain, is, are we sort of chasing windmills here? So, I mean, let's go back and let's go digging around, at least analogously, in Mendel's garden. As you know, in genetics, one of the things can happen is a single gene can lead to multiple effects, phenotypes, and multiple genes can converge onto a single phenotype. And the same thing in some ways seems to be the pattern of node and network activity in the brain, where these things that we see as our motions, cognitions, and even behaviors may be tokens of underlying brain activity, which would then lead to, well, how do we know that the patterns that we're seeing in the fMRI are in fact valid patterns and reliable patterns, particularly if we're using these to make critical decisions about how we regard and treat those patients? Thoughts on that?
So it's a great question. I mean, one of the challenges is, and this speaks to your point, people who were in the minimally conscious state, who may be able to intermittently follow a command, not consistently at the bedside, may not be able to do this task in the scanner. And so you get different kinds of errors. Somebody could be in the scanner and not be attentive and be potentially able to do the task, but not be interested. They may be apathetic. They could be sleepy or they're tired. So one of the things that one of the sort of the ethical hallmarks of this is a positive result becomes much more dispositive than a negative result. We don't necessarily trust the negative result because then we label somebody as permanently whatever, when in fact they may have this potentiality. And there is a bedside test that Joe Giacino and others have developed called the Coma Recovery Scale Revised, which is a bedside assessment of neuropsychological testing. So these things happen in tandem. But one of the things about that test is you can't just do it once. You need like 5 tests at different times of the day, and your best response is the response that indicates what your functional level is. And it's like, we have better times during the day for each of us. There are times in the day when I write, and there are times during the day when I read, and there are times in the day that I take a nap. And so we have different levels of functionality. And one of the things about consciousness that's really important is that it's not just cognitive integration, it's also the level of arousal that comes up from your brainstem. So if you don't have the requisite arousal, that a lot of these people with disorders of conscience have arousal mechanism problems because they're not getting enough energy, as it were, from their brainstem, that then becomes the platform for the integrative higher functions. So we need to take multiple assessments during the day, and you need 5 assessments to really make an accurate evaluation. One of the things about this is that I think we're learning. We're sort of charting the brain, like it's kind of like we're in the peri-DNA discovery period, and we're learning about the mechanism of inheritance. We're learning about the mechanism in the brain, and it really is their discrete circuits that begin to describe certain functions. And by mapping and intervening on these circuits with drugs or devices, we're going to be able to understand the accuracy of our interventions. But ultimately, it does result in a phenotypic expression. But the phenotype can be, behavior, which is a traditional phenotype, or it may be a signature on an fMRI, which becomes pathognomonic for a strong response to that's a proxy for the behavior. But these are methodologic problems, and that's why you have to be very careful about using the scanner. The other thing I just would add is temporality, that the brain is evolving over time, and a scan you get today for somebody who's just had an injury 3 months ago, if it labels them as permanently vegetative or something like that, they may be in a very different place, in 6 months or a year. And speaking of temporality, again, if you go back to the Plum and Jeanette paper, which is really worth a good close read, they debated the vegetative state. Should we call it persistent or permanent? They decided on persistent initially. And then in '94, there was a multi-society task force report in the New England Journal of Medicine. They said, okay, if it lasts a certain amount of time, it's permanent. But in 2018, they got rid of permanent, and they said now it's chronic, because some 20% of people who were thought to be permanent, in fact, can go to a higher level of function, which reveals the importance of time. It also reveals our fallibility. So we have to have what I've written about, I call it nosologic humility. We have to have humility in our diagnostic categories, because it's an evolving science. And everything that I'm talking about now would have been science fiction or heretical 40 years ago when I was a medical student. And it's exciting that so much has changed, but so much else needs to change, and I'd like to pivot a little bit away from the science to our moral obligation to these people, because the vast majority of people with brain injury end up not getting the care they need and lingering in nursing homes unattended to, not getting any surveillance about if their brain is changing. It's not likely that anyone would notice or care to notice. And that's a tragedy.
Yeah, but this is an important point. So let's apply that morality in 3 different ways. Number one, let's focus it through various ethical lenses, because as we all know, ethics are not necessarily uniform. It's a toolkit, and very often the best articulation of the task is to use multiple tools in some way.
Right.
Point number one. Point number 2, you've got 2 things in evolution. You've got the evolving brain. And of course here, as we know, brains develop embodied in that organism that's embedded in their environment and their ecology. And the old adage in much of neuroscience is see one brain, because the devils and deities live in the details of that circuitry. And the other issue is that the injured brain, as you well pointed out, may not necessarily respond as the healthy brain does. Each of these things would tend to recommend a prudent prompt, a pragmatic prompt, engage these neurotechnologies, at least imaging technologies, if not then more interventional technologies like brain-computer interfaces, in those ways that are far more ubiquitous. I mean, let's face it, this whole issue of is there something there, and the basis of whether there is or not dictates our moral regard and our moral and practical treatment would suggest that, yeah, these things are intersecting. So in terms of the science and technology and the changing brain, if you were going to develop a paradigm, I mean, literally, if you were master of all for a day, and you're going to implement this paradigm to use this technology in those ways that are, as you said, prudent, phronetic, how would you do it?
Well, I think to not identify someone who's conscious is, I think, it's an unexcusable error. It's an error of omission, and we should do our best to make sure that nobody slips through those cracks. And I would probably say at a certain time, at certain intervals after the injury, I would want to go back and do a multimodal assessment of people to make sure they haven't regained consciousness, because our obligations change. I mean, simply put, if you're conscious and you have intact neural networks, all of a sudden you could probably also perceive pain. Vegetative patients cannot perceive pain because they do not have integrative function. The pain network doesn't light up if you test them, for example. But people who are covertly conscious probably have the ability to perceive pain. So we could, I have cases in my book where people were getting procedures done to them without adequate analgesia and anesthesia. And that, I think, is just a kind of a horrific abuse of human rights. So I would want to make sure that we're not missing consciousness, covert or otherwise. The issue you mentioned about the evolving brain and the developing brain and development embodied in ecology is a really important point, because one of the things that we've learned is that the very injured brain, after a period of latency, uses a developmental process in the service of repair and regeneration. Let me explain that. So Terry Wallace, who was a man who woke up after 19 years of being thought to be in the vegetative state, but was in the minimally conscious state for most of that time, and who just died about a year ago, who I wrote about in my book, and I just wrote a piece for the Issues in Science and Technology published by the National Academies that came out actually this Monday, talking about his life and death. But Terry's brain, 19 years after his injury, revealed the process of axonal sprouting and pruning. And so some stem cells got reactivated probably and created new white matter in his brain that probably became the substrate for his improved function after this long period of latency. And what that is a recapitulation of the developmental process you see in children and babies and infants. And that's how we wire, and that's why, the age of majority is 18, because that's when they wire up your frontal cortex and you have executive function. So that shows a biological basis for the evolution of the brain in time. I think the other thing is to be very aware of the need not to have a sense of stasis. So if I was in charge of the universe for a day, I would probably look for some low-tech technology like EEG, which has been demonstrated to be able to do this, that can use prompts instead of putting someone in a scanner where you need a cyclotron and isotopes and all that. People like Jan Clausen up at Columbia published an article in the New England Journal of Medicine a few years ago showing covert consciousness in the ICU, not just in chronic brain injury, but in acute injury in people who were thought to be in a coma, and people who had covert consciousness based on EEG prompts had a better prognosis a year out. One, their brains were healthier, but two, when you told the family that their loved ones were conscious, they interacted with them differently. And we are social animals, and that probably had a therapeutic and a salubrious effect on the person's recovery. So I would want to do surveillance, and then finally, I would want to prevent the tragic deaths that are avoidable. Just to speak about Terry Wallace for a minute, who, as you know, Jim, became super famous, and his emergence after 19 years. He had been in a car accident in Arkansas in 1984, and 19 years later he wakes up in a nursing home. His first words were "Mom," and then Pepsi, his favorite drink. And his family thought he had been interactive, but they had been told, it doesn't matter. He's not going to get better. He's in a vegetative state. He's not going to respond. And then he wakes up, and I got to know his mom, Angeli, and I speak about him with the family's permission, both Angeli and more recently his sister, Tammy Bays. And so he became a very famous guy, and then he dies in March of last year. But in February, Tammy calls me up, and I tell this story with permission. This is delineated in the Issues in Science and Technology, because he wasn't getting the care that he needed in rural Arkansas. The intersectionality of being poor in a rural environment, not having access to rehabilitation, and sort of the residua of the right to die movement, because people like him, were the basis of the right to die. So they couldn't possibly have a good quality of life. So why should we really try as hard as we can? And one of the doctors, according to the family, said to Terry and his mother, Angeli, who he was incredibly close to a few years ago, and he misses her. And Terry's sense of time was distorted, whether he knew it was now, or he had a hard time processing time. So one of the doctors said, "Terry, do you want to be with your mother?" And Terry said yes. This is as he's getting sick with the pneumonia and everything. And the doctors thought that was his request to let him die and be with his mother, who had passed. The family was alarmed by that, called me, and we tried to work with the doctors. And so I think that it gets me to my other point, surveillance, but also good medical care. He needed pulmonary toilet. He needed pulmonary rehabilitation. He was still finding meaning and joy in his life, and he had a family that deeply loved him. So I think it's not just the high tech stuff. It's the TLC. It's the low tech stuff that we need to also pay attention to. Great nursing care, concern for the well-being of these people. After I say all that, the next question from people are, so how much is this going to cost? Right? I mean, the cost factor, and I get that, but if we can identify people and be aware of their consciousness and perhaps their ability to communicate with us, we might be able to decrease costs, because we'll have improved advanced notice of their conditions, and we might be able to have them be more functional, less bed sores and the like. So the person who gets deep brain stimulator, once it becomes therapeutic, and we're still in the experimental phase, investigational phase, may be able to eat by mouth, maybe more mobile, may be able to have less bed sores because they're getting out of bed. It may be cost effective to put in as a stimulator, because we're already paying for the chronic care costs. If we could use that cost differently, then I think it might be cost effective. But it's not just about cost effectiveness; it's about the value of these individuals and their lives. And I think that as every time we have a neurosurgeon go into the emergency room, which everybody says, "Oh, we have to do that," we also have to think about the associated costs of chronic care and rehabilitation that goes with it. We dichotomize outcomes, like everybody gets better or they die, right? But the vast majority of people, even people like Abby Gifford, who was the beneficiary of great care at the Texas Rehab Institute in Houston, she still has an ongoing challenge. She's made a remarkable recovery, but there are costs that are associated, and we have to be willing to pay those costs. And we have veterans. You are a veteran. Thank you for that service, Jim. We have the signature injury of the Iraq and Afghanistan war was traumatic brain injury. So we have hundreds of thousands of people from concussion to more serious injury. And so I think this is politically not a red state issue or a blue state issue. This is a purple issue that benefits our military veterans, our wounded warriors, as well as civilian population. And I think it's also the right thing to do. Politically, it's a winner, and I think it's the right thing to do. And I think the excitement in neuroscience right now, the fact we're on the cusp of things that were unimaginable, that we can start to do. We have to bring the fruits of neuroscience forward to people who are now, stuck in their heads, waiting to get out.
Let's hinge on that a moment, because there's a lot to unpack, and I think a lot of it really speaks to the applicability. Ed Pellegrino, as his working mantra, said that the prudent actions, the phronetic actions of medicine,
Right.
are determining what can be done for this patient at this time for these reasons, and what should be done in resolving equipoise and then moving ahead with that patient as a psychosocial entity. So a couple of things here. I mean, I think, as you well remember, a few years back, there was sort of an open forum as part of the European Union Human Brain Project that looked at the viability and the translational value of putting neurotechnology to work in those key areas where nothing else works. And this then speaks to some of the work, for example, of Katinka Evers from the University of Uppsala, who we both know quite well. She talked about using neuroscience, neurotechnology to, quote, recover consciousness. In other words, that it's there. You have to uncover it or recover it. This paper appeared in Frontiers and got a lot of attention because it was around the same time that your book had just come out. But I think there's another issue here that speaks over and above temporality. A few years ago, working with our group, we had Professor Karen Herrera, who's down in Mexico and also in Texas. And one of the things that she's very interested in, as you know, from the work in neuroethics, is the idea of globality and multicultural uses, which then also speaks to the affordance issue. I mean, it speaks to the ecological as well as the economic basis of ethical use or non-use of these technologies. And one of the questions that came from our listening audience, I think, speaks to the same type of issue. And if I'm going to paraphrase this, and this comes from Dr. Esha Ray Chuduri, who says that as a member of the BIPOC community, what very often happens is you see these ecological and economic variables that affect regard and care. So the issue here is, can we use these high-tech methods to perhaps develop lower tech methods that are far more ecologically variable? And what does that then mean for putting, if you will, this thing into action?
Right. So this is precisely, this is a really important issue, because this is a problem for places that have neuro ICUs and scanners and the like. So one of the things, I'm involved with a group called the Curing Coma Campaign, which is part of the Neurocritical Care Society. And it's an international organization, just like the International Neuroethics Society is an international organization. And Karen is one of our board members of that organization as well. So this is a global phenomenon. Brain injury is a global phenomenon. Stroke is a leading cause of neurologic death around, I think, the world. So one of the things that we're trying to do is figure out a way of bring low-tech measures to underserved areas like EEG, which pretty much every hospital has EEG, and determine a way of, and we're actually talking about this currently, of extracting the signal and having it sent through the internet to a place where the algorithms can be applied to deconstruct, is this covert consciousness or not? So in other words, bring the technology, which is readily available, disseminate it, EEG, and then transfer the data to places where that can be interpreted. Because we have to have equity across regions. Having said that, I think it's important to realize that by not providing care to people here who are in Georgetown or Weill, Cornell or something, who have a severe brain injury, it doesn't necessarily mean that those resources are going to go to another part of the globe. Norm Daniels, a philosopher, talked about closed systems of justice. And he was talking, say, in the British healthcare system, if you don't provide care to an octogenarian, you might be able to provide better care to that octogenarian's grandchild and getting prenatal care, because it's a closed system of justice. The global health community is leaky, and we don't actually have a closed system of justice. We saw that with COVAX. We see this with COVID vaccines. We're still under-vaccinated, not by choice, but by access and distribution in vast regions of the world. The people in New York have had 5 vaccines, or people in the global South who've had no vaccines, and that's a different kind of inequity. So I'm totally with you, but I think we also have to, beyond population health, think about the dignity and the needs of the individuals. And we have deontological ethics and utilitarian ethics. The health justice think is a more utilitarian ethic, fair distribution to lots of people, maximal benefit, simply put. But there's also the suffering of the individual. So I've really, embraced the disability rights perspective on the needs of people with severe brain injury. And I think that for us, and I say us in the disability rights community, we have to move beyond sort of the ADA vision of it in the 90s, early 90s, where it was a cut in the sidewalk, which gives people who have motoric disability access to the workforce and their families and mass transit and the like. For people with disorders of consciousness, the way into the room is through, one, the identification of consciousness and the restoration of functional communication through neuroprosthetic devices that allow them to interact with each other. It's like, so, in fact, right now, you and I are interacting. We're not in the same room, but you nodded your head through the vector of technology. And one of the great things for people with disabilities has been, in a paradoxical way, the pandemic, because they can participate on Zoom in ways that they may not have been able to participate before. People who had social phobias are more able to participate through Zoom than they were before. So I think that the pandemic made us all, in a sense, disabled, because we couldn't go out and we had to accommodate. If we can remember that lesson, that sense of isolation, and how we sought to remediate that for people who are now still isolated, sort of as the pandemic is waning, we hope, we all appreciate our responsibilities. But one of the paradoxes that I've been working on with my students at Yale Law School is this paradox. The Americans with Disabilities Act provides great protections to people. It's like sort of the next phase of the civil rights movement. But it's predicated on the fact that you have an immutable condition. But as the neurotechnology makes you better, you now have a mutable condition, and paradoxically, you'll have less juridical protection. So we've just proposed in a paper that was published last year in Boston College Law Review. I proposed the idea of an Americans with Abilities Act, not Disabilities Act, but now newfound abilities through the benefit of neuroprosthetics and drugs and devices, so that now we think about maintaining protections, but also helping to facilitate people's reintegration into society, because the whole mandate of the ADA was to overcome what Justice Ginsburg called, what Congress described as segregation. People who are disabled are segregated. Right. So the idea here, functional integration, is the mandate. So when Ed Pellegrino, who I greatly admired, said what can be done and what should be done, the challenge is what can be done is evolving, and it's great, right? As doctors and scientists, the possibilities are greater, and I think now that we can do more, we should do more, because one, we recognize where the deficits were. We didn't know about covert consciousness, but now we have a means to identify it, we means to remediate it.
But I think this is a great point, because one of the mantras of the disability movement, as speaks to both research and its translation, not only into clinical medicine, but into social practice.
Social context, right.
Is nothing about us without us.
Right,
but
right.
Evidently,
right.
The individual who may have covert consciousness is axiomatically, at least before, non-contributory to that discourse.
Right.
This may serve as a bridge. So here's a question for you. I mean,
bingo.
Yeah. So
you win.
This is one of those things that keeps coming up over and over again. I mean, our colleagues, for example, who are working at Gallaudet here in DC, for example,
right.
Laura Ann Petito has talked about whether deafness, the biological condition of deafness, how does that impact, if you will, the existential or ontological big D deaf that then represents these individuals' sort of existence, right? And what that means. Here too, one of our working colleagues, Asya Paskalev from Howard University, has talked about the idea of revising futility in neurological contexts based upon what the brain science, as you're describing, can do and what we should do in response. But I have a question for you, and it's a real question. It's not at all rhetorical. Working with colleague John Shook, for example, one of the things that we found, and you remember the study quite well, is that civic institutions may not be ready to be able to handle this new habilitation, if you will, that these neurotechnologies may afford.
Right. Okay. You've asked me a lot of questions, and and it's a rich question. So I'm going to go back to the beginning about communication. And one of the things, the connections that I make is between the restoration of functional communication and its cognate community. Mm-hmm. And you restore community through restoring functional communication. With respect to people who communicate differently or people who are deaf, I think there's a translational obligation to try to understand people, even if they're not speaking in ways that are traditionally familiar to us. And the burden is on the hearing to understand and to get translation services. And in fact, I wrote a piece in Harvard Journal of Law and Law and Technology with Karen Lawrence and Zach Shapiro a few years ago, where we were talking about what constitutes an adequate evidence of understanding in the courts, right? As far as testimonial evidence, if somebody's saying something. And we said that the burden shouldn't be, kind of a legal, juridical burden, but more of a clinical burden with a desire to try to know and to understand, and that the obligation is on us to try to understand what someone is trying to say, to give them the maximum ability to communicate. So nothing about us without us presupposes you're able to communicate. Right. And the holy grail for us is functional communication. And so there's a great Spanish film that won a bunch of Academy Awards by Pedro Almodovar. It's called Talk to Her. Oh, yeah. And it's about two women. It's a kind of a crazy movie, but they're two women who one is vegetative, one's minimally conscious, one was a ballerina, one was a bullfighter. Complicated story, but it was mistranslated in English as Talk to Her. But in Spanish, it's hable con ella, speak with her. And that con from with to two, it's the con or with is about this reciprocity. And with the language, talk with her, you're developing a community. So I think language is really, really central to this. And seeking to understand the other is really, really important. Now, this issue of what society is ready to handle or not. Well, there are a couple points. 40% of us outside of our immediate death will become disabled in our lives. So most of us will be about us, right? Most of us will have some kind of disability, and it's not about them, it's about us. That's the first point. The second point is we have to become habituated and comfortable with things that historically have been uncomfortable for society. So, and sometimes the law is wrong, right? So Plessy versus Ferguson was the law until Brown v. Board, and it was not. And I think that the way we treat people with disabilities, and especially people with brain injury and disabilities, because of a kind of a misplaced generalization of this right to die, is a violation of their civil rights and their disability rights. And we have to get habilitated to seeing that as wrong. I think our children, that we have had a sequence, the arc of justice generally has been moving in the right direction. Not always, but generally so. I hope that in 20, 30 years, our children, our grandchildren will say to people of our generation, what do you mean? You treated people who were conscious that way in nursing homes? Mm-hmm. And it'll be as incredulous to them as certain kinds of discrimination that we've learned was wrong today is to us from our predecessors. Some of the behaviors that were current in the 60s and 50s, we do find intolerable. I hope that this arc of justice moves in that right direction. And I think the science, the technology is pointing that arc, that compass in the right direction towards a more inclusive space for these people.
This is interesting because Professor Thilo Hinterberger in Germany has done an awful lot of work with utilizing brain-computer interfaces that are hinging upon just these type of data, the type of data that one would get from not only neuroimaging, but then relating neuroimaging in some type of, if you will, technological effectiveness ratio to the use of lower tech means to be able to assess there's something there, and then get to that, access that. And, Professor Hinterberger had an interesting quote. He said, in some level, given the subjectivity of consciousness and that it's transparent only to the person who experiences it,
Mhm.
The big goal here of these individuals is trying to objectify these subjective states. So in that way, we're all, quote, locked into some dimension.
Right.
How do you see this particular type of approach that you're dealing with the chronic and persistent vegetative patient being used in other forms of neurological disorder that may equally, for example, impede communicative capability, like locked-in syndrome?
Right. So locked-in, just to define it, locked-in syndrome is essentially normal cognition without any motor output. But I think the issue here is the only consciousness that I truly know is my own, right? And I can infer you're conscious because you just nodded your head, right? I mean, that through the vector of communication, your language, your manifestation is a proxy for your consciousness. So I think we're never going to be able to get inside that subjective experience with a kind of, falsifiability, because there's no way to really prove that I'm conscious or that you're conscious or not. And it's really through the functional transactional interaction of language that we come to know that. But I think that's okay, because I think that's the way we operate, in all realms. But I think what we're learning about covert consciousness and impaired forms of communication, even in people who are conscious, may ascribe to other forms of deficient output. Right here, we're talking about lack of motor output, but it could also be a lack of emotional output.
Mhm.
So people who are artistic, who have very rich computational minds, if they're not properly accessed, that technological or computational brilliance is obscure. It's hidden behind a lack of emotional connectivity. So I think, one of the things this is one of the reasons why neuroscience research is so important, is that by learning about one domain, we might unearth ideas for other domains. And what you learn in brain injury and covert consciousness may have direct relevance to autism, or vice versa.
Mhm.
Or what we learn in childhood neurodevelopment may have relevance to axonal sprouting in the injured brain, or vice versa. So even within neuroscience, as you know, there are silos that need to become more osmotic, have better osmotic gradients, so we can cross fertilize, and using all kinds of metaphors here to improve our knowledge. But I'll stop there.
A final question for you, which is really,
Yeah.
so it goes along with something both you and I like to use in the lectures that we give, that you don't want to untangle the Gordian knot of the brain mind only to open a can of worms in the way you use this stuff, right? So let me open a can of worms for you here. I mean, clearly what we're talking about is harnessing neuroengineering and neurotechnologies in those ways that are depictive and elucidative of consciousness. Do you see this also perhaps being used in some of the ways that Mike Gazzaniga proposed a few years ago? In other words, looking at the prenate to determine what conscious processes are there and making particular inferences and meanings that may have moral and ethical value, as well as at the end of life. So
Yeah.
Thoughts on that?
So I believe in inductive moral reasoning, and I really think that conflating, the end of life debate with the abortion debate and with consciousness, that these are particular scenarios, and people can be all over the map, because the particularities of each of those circumstances are distinct and discrete enough that if we start trying to have a unified field theory, we might alienate people, and we might confuse the circumstances. I think that there's enough difference, okay, between a vegetative brain and a minimally conscious brain to keep me active for the next 2 or 3 centuries, right? To begin to talk about the developing brain in that context, and when and what constitutes a life, right? I mean, is it fertilization? Is it consciousness? Is it, I think it gets very complicated, and I think, given the political community that we're in these days, it's not productive. I would rather achieve consensus on the things that we can agree on. I think it's interesting when you talk about brain injury, and I speak around the country, and when I'm in the Northeast, I might talk about civil rights and civil liberties and disability rights. When I'm in a redder part of the country, I might talk about respect for personhood, and the dignity of the individual. So I'm saying the same thing. I'm using different language, but one may be more politically acceptable in that context. So I really think we need to be careful. Having said that, I would say, and I just finished writing with a colleague a paper about Dan Callahan, and his theology and his secularization. You know, one of the things that concerned Dan was, who was one of my mentors at the Hastings Center, was perhaps the over secularization of value choices and ethical conversation. And even though he left the church really never left him as a kind of a cultural Catholic and somebody who struggled with his faith and his commitments. And I think that the schismatic that exists in American public life between your secular or your religious, and there's no zone in the middle for people to talk about shared concerns and values, has been to our detriment. And it has eroded the possibility of consensus, and people are speaking different languages. So I think, you know, I was talking about a translational function. I think it's incredibly important that we cross that theocentric divide, and we look for commonality and common space, and try to do the good work that comes from respect of our fellow beings, ones who are in need, those who are vulnerable, those who are sick, those who are injured, those who care for them, those who provide care for them. There's a lot in the Judeo-Christian, Islamic, and Hindi traditions and other religious traditions and in secular traditions about making the world a better place. So I really think that we should rally around that common cause, and do so in a way that's pragmatic. As John Dewey said, to reconstruct the good, to build, on those possibilities.
Wonderful note and tenor to end this discussion with. Unfortunately, we've come to the end of our time together, and the hour flew by, certainly for me.
I know.
Joe Finns, always a pleasure to talk to you, whether it's oversharing a favorite drink in a bar, at a conference, or in this forum. And again, thank you so very, very much for joining us. And thanks to each and all of you in our participating audience for your attention to the John Collins Harvey lecture series, and certainly to our speaker today, Dr. Joseph Finns. Joe, thanks very much, and thanks to each and all.
Thanks, Jim. Great to be here.